டாக்டர் நீங்க இது ஓகே ஓகே பாருங்க ஓகே கை எடுத்து ஓகே போலாமா போட்டு சைலண்ட் போட்டுக்கலாம் அது ஓகே 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 மைக் மட்டும்
We can't have இது வந்து handheld தானே? Do we have a meeting and we can fix it on the boards?
No. One replacement center. That's it. This is for you. Silent.
I think that will disturb you. இல்லைன்னா switch off பண்ணிடுங்க. Switch off பண்ணிடுங்க.
பேசுங்க.
Hello.
அவங்களுக்கு மட்டும் கேட்குறேன் ஆன் பண்ணிடுங்க.
Hello. Hello. Hello.
கரெக்டான
Good evening.
அது கேக்குது இந்த மைக் செக் பண்ணு. போயிடலாம் கேக்குது கேக்குதா
ஒரு நிமிஷம். ஓகேண்ணா.
Okay, pain to I can sit back only.
கொஞ்சம் தள்ளி. ஓகே.
On behalf of the team of Varam IVF, we welcome you to this YouTube live session on solutions to struggles in fertility care. I am Dr. Rajini, consultant, IVF and reproductive medicine, Varam IVF and Healthcare. I have with me two elite panelists, our HOD, Head of Department, Dr. Darshanti Madam, and our senior consultant, Dr. Vanitashri Madam. So for sake of convenience and to elaborately discuss on the fertility care, today's topic we have divided into A to Z of infertility care. We will be almost covering the entire topics of fertility. In case there are any doubts, you can put them in the comment section, which we will take it up at the end of the session. So we would now directly go into the session with the first alphabet A. So A for AMH or anti-mullerian hormone, the most preferred investigation of choice for clinicians all over the world. So Dr. Dakshanti ma'am, can you just throw some light on what is AMH, what is its normal levels, and its significance in infertility?
Good evening. AMH is an important hormone to be evaluated in any woman who is coming for fertility care. AMH is anti-mullerian hormone. It is a hormone which is produced by the granular cells of the ovary, and it actually determines the ovarian reserve. So normal levels of AMH could be between 2 to 4 nanograms, but then we have seen that many women after 30 years of their age, they start having lesser AMH because the ovarian reserve equally comes down. And there are other causes also where you see that the AMH might be low, as in cases of previous ovarian surgeries where one ovary has been removed, or there was endometriosis or cystectomy has been done, where the ovarian function has been compromised, and there will be less AMH in those cases. There is another condition where we have called the polycystic ovarian disease or malformation, where in this case the AMH levels will be high because there are multiple peripheral follicles which are producing more of that hormone. So depending on this AMH, we usually assess our patients. I mean, I feel it is one of the, as Rajni mentioned just now, it's one of the important tests which has to be checked in all women, whatever their age may be, when they are coming for fertility treatment, so that we can assess and guide them accordingly. If it is very low, we should be taking them to more assisted reproductive technologies like IUI or IVF. But if it is good levels, then we might as well treat them with medications, or we might treat them a bit slowly with advising them for natural conception also.
Explained. So moving to the alphabet B for blocked fallopian tubes. So as we know, fallopian tubes are important structures which connect the uterus and the ovaries. It's very important from the reproductive aspect because fertilization happens here. So when Vanita ma'am, can you please tell me what are the causes and how do we diagnose a blocked fallopian tube and how do we manage it?
Good evening, all. Fallopian tubes, it's very important structure for fertility. So, what are the causes for blocked tubes? Commonly, we have pelvic inflammatory disease. Every woman goes through one or two vaginal infections in our life. So, commonest is the pelvic infection, which we call as PID. The commonest organism will be chlamydia and gonorrhea, followed by sometimes when we have previous surgeries, we can have a lot of adhesions in the tubes, and that can prevent from becoming pregnant, or it can cause even blocks. And endometriosis is a very important factor which causes the damage to the tubes. And previous surgeries and pelvic adhesions per se can cause blocked tubes, and even fibroids. So there is a conval fibroid or something like that, it can cause a fallopian tube block. So the diagnosis of fallopian tube block is by we have three modalities. Commonly, we do something called HSG, which is nothing but the hysteroscopy. This is a very simple test which is done when the couple come to us with infertility. It's an OPD procedure. We can do it within half an hour. And here we just we do it within first 10 days of cycle after the menstruation stops. Here we just make a patient lie down. We put a dye into the uterine cavity, and we take an X-ray from above and see whether the dye has come out through the fallopian tubes. In this way, we can find out whether the tubes are open, patent or not. When we see the spill, it means the tubes are open. The second thing is saline infusion sonography. The same thing can be done by using an ultrasound machine. Instead of an X-ray, we use an ultrasound machine. The third thing is laparoscopy. This is very important, and this is a gold standard in diagnosis of fallopian tube blocks, because sometimes in SAS and HSG, which I explained you before, we can have the report as bilateral tubal block. But when we go and do laparoscopy for these patients, most of the times, like out of 10 patients, 6-7 times, we see both the tubes are patent. That is because of the spasm or because of the pain. There can be spasm, and that can manifest as a blocked tubes. So laparoscopy is the diagnostic tool, I can tell you. Here again, this is the extra thing that we have to do here is it's a small surgery just be done under anesthesia, and here we inject the methadone into and see the same thing live. Instead of seeing an X-ray or an ultrasound, we see it live with the camera. It's more of a direct testing. Yeah. And the other thing is it's both diagnostic and therapeutic. If there is anything else, we can even clear it out at the same setting. So this is the diagnosis part. Management is again there. It depends if there's a single tube block or both the sides block. And two things we have: one is tubal cannulation that can be done through hysteroscopy and laparoscopy. We can try. The other thing is if we can't remove the block even with cannulation, then we have to go for assisted reproductive techniques like IVF.
Thank you. That was really good. So moving on to the alphabet C. C for causes of male and female infertility and the role of counseling in IVF and
When it comes to the causes of infertility, we all know infertility means that a couple is trying sincerely for a year's time unprotected sexual intercourse, but then yet the wife could not get pregnant. So in these cases, we take it as a case of infertility. It could be primary, as in 1 year of trial, and then they did not conceive for the first time also. But it could be called as a secondary infertility if the couple had already had conceptions, but does not have a live child, or has a first live child or 1 or 2 live children, but they are trying for long for the next conception. So this is secondary infertility. So when it comes to primary infertility, we have to see the couple as a whole. Like we can't differentiate. I mean, they gone are the days where people thought that the woman was the reason for infertility. Okay, so it could be like investigations on the part of the woman to find out what her problems. So broadly, we can classify it into primary infertility, secondary infertility. In that, we can, in women, it is actually thought to be like uterine causes, where there is malformation in the uterus, and it could be congenital or because of later on developing fibroids and all those things. It could be because of the blocked tubes, as just Vanita had explained. It could be because of the ovarian causes where the ovaries have problems like atretic ovaries, like ovaries, streak ovaries in case of Turner syndrome, or it could be like low ovarian reserve in even younger women also. We have seen that they have a very low AMH, even 28, 29 also. I have actually provided donors for some women where their AMH was very, very poor, like less than 0.1 and everything. So in these cases, the ovaries will be very small and they will be atretic at an young age also. And it could be other causes like endometriosis, it could be causes like PCOD. All these things come under the ovarian causes. It could be the male factor where actually the husband has abnormal factors, abnormal parameters in his sperms. That is, it could be the count might be less, the morphology might be poor, less than 4% morphology is again abnormal, or the motility might be impaired. It could be very low motile sperms also. So all these come under the male factors. Of course, other things like genetic causes also do surface up when we are investigating them. Other reasons could be like combined factors where we have seen these days, like the man also has a low count and the woman have a problem like PCOD or a problem like endometriosis. So these are combined factors. And then 1% of it, which has unexplained infertility. We investigate the couple, but we find nothing wrong with them. So in these cases, we call it as unexplained infertility. Counseling actually forms a very, very important role in IVF units, because it is our counselors who are actually talking in length about the couple, their family, and sometimes we come to know when patient is talking to me or the husband and wife is talking to me, they might not come up with many things the woman is facing in her house. But when they talk to the counselor, they are coming out with many other factors like the husband's family is not supporting her, or she might not be in a good relationship with them, and all those things. So counselors play a very vital role in our team. And even when I am actually telling that this patient requires IUI, this patient requires IVF, they need to be counseled for the program because they have their own fears, whether I'm going on the right track or I've tried of hormones, I've tried of the procedure, all those things. So the counselor actually can give lots of advice and counseling on this regard, where the patient is more positive when they're coming up with their treatment protocol.
Now we elaborately spoke about the causes of infertility. So moving to the diagnosing male and female infertility.
When we want to diagnose the evaluate the female and female infertility, for males, first very important is history taking. Whether it's male or female, first detailed history should be taken, and then we have to go through the general examination about the DNA of both the partners. And after doing the thorough history and examination, then we go into the blood investigations and loss the scans. So as far as blood investigations are concerned, for male, we don't know blood investigation. We do basic general investigations to thyroid, sugars, and all that. Then we go for semen analysis for the husband. And when we are doing a semen analysis, we have to instruct the husband how to correct it. That's very important. And if they are having any difficulty in collecting it, we have to help them out. And then after semen analysis, if there is any problem with the semen, as one explained, there will be low count, low motility, then we go into further testing of the hormones. We have to do FSH, serum LH, and testosterone for the males, and also we have to do an ultrasound with this program and Doppler study with this program. This is for male partners. As far as females are concerned, again, thorough history examination, and very importantly, with BMI of the patient, and then basic blood investigations like hemoglobin, thyroid, sugars, prolactin, and all that. Then come the hormones, FSH, LH, and very important hormone here is AMH test, which is discussed in detail as first question for us. And at last, we do an ultrasound test. All these things can be done in a single setup itself. The patient may not come like 3-4 times for all these things. It's very easy. We can do it all. In the first visit itself, we can do all these things and we can come to a conclusion diagnosis and we can give them a plan of management.
So, I think the success of IVF or any fertility treatment, it requires a very good team of scientific people who can adequately support. So, coming to the team, I think one of the most important pillars is the role of embryologist in an IVF lab. So, Dakshina, can you please tell me what is the role of embryologist in an infertility unit?
Yeah. Actually, when it comes to fertility treatment and an IVF unit, we are clinicians. The three of us are the clinicians. We are first seeing the patient, examining them, investigating, diagnosing, coming for a plan. But then we have the more important people, which is the scientific team. The scientific team are the andrologists, the embryologists, who are actually doing or dealing with the gametes. So the embryologist plays a vital role, and I would actually call them the heart of the IVF lab, because they are the ones who are actually creating the best embryos for us, through which our success rate or our patient results are good, so that anyone who comes to us know, like they go home with a bundle of joy. That is the ultimate thing which we can actually do. So the embryologist is usually a scientific person who is dealing with the oocytes and gametes. So their role is to screen the oocytes when we give the follicular fluid in the egg pickup. They screen, they count how many oocytes we have retrieved, and then they wait for the maturation. And after maturation, the M2, that is the oocytes which are maturation 2, when those only actually will be injected with the sperm. There is even conventional IVF also, which is natural selection of the sperms, which can be done by letting the sperms, prepared sperms with the oocytes. So this we can do when there are many follicles and many oocytes retrieved. We can actually make 50-50 of conventional IVF over ICSI, that is intracytoplasmic sperm injection. So intracytoplasmic sperm injection also is done by the embryologist only. They follow these embryos, they do the first check on the next day, then they do the day 3 cleavage stage, they tell us, and on day 5 is the blastocyst, which usually is frozen. Because these days we are actually following more of frozen embryo transfers when compared to fresh embryo transfers. So all this work is done by the embryologist. They are the soul of the embryology lab. And they also, not only this, they also help us in cases of PISA, where the male factor is involved, where the sperms are not available in the semen sample, but we can directly take it from the epididymis, as in cases of obstructive endometriosis. So in that cases also, the embryologist plays a vital role, where the tubules will be taken and given to them. They will actually extract the sperms there and freeze the sperms in before we actually go for the IVF program. And they also do what is called the pre-implantation genetic testing of the embryos. That is, biopsy of the embryos is also done by an embryologist. So they really play a vital role. And if we are getting good results in our labs, I would actually put that they are also like 50% the reason for the management of that case.
Can't agree more on the role of embryologist in an IVF unit. So moving on to fecundity, it is the ability of a couple to conceive. So Vandana, can you please tell me what are the factors that are going to enhance or diminish fecundity in a given couple?
Yeah, it's just the potential of the reproduction. So fecundity, we can improve it. Because of the lifestyle nowadays we are having very decrease in the rate of fecundity. So first thing is we have to talk to the couple. Main thing is nowadays people are not getting married late. They are all career oriented. So they are starting that we want to plan for it pregnancy very late. So we have to really talk to these couples, or we have to create a lot of awareness programs where we have to tell them that age is very important factor as far as reproduction is concerned. People all know, but they still think it's okay, we can delay for a few years. So we have to tell them to really stay together, get married early as possible, depending on their situation. The second thing is after marriage, they have to plan for pregnancy as early as possible. And then next is their lifestyle again. So if they are working, husband sometimes they work abroad, wife is here, so all these things matters a lot as far as situation is concerned. So we have to tell them about all these things, and also we have to counsel them about their lifestyle. We have to talk to them. Right? When we talk to them, and we have to tell them about their BMI, their producing weight, both their partners, not only for females, not only for males. So we have to talk to them about their lifestyle, like smoking, alcohol, and their work pattern, their shifts. If you are in a night shift, they have to try to make it a day shift. So all these things will help them in reducing their stress, and all these things will really help them to have really a good rate of fertility for them. So in India right now, it's only just fertility rate is 2.
So actually, fertility also means how many times a woman would conceive in a 1 month if we are going to take. So it is as low as only 2 months. Only in 2 months everything would be put into place.
It has
So
come down over the years.
yeah, like
Not just the way it was
4
4
or 5 when I was now starting to do my fertility practice and all. Now it's gone to 2.
really, it's like it's a concern,
coming down.
and we have to really give a lot of awareness to the young couples.
So I think moving to the next topic, one of the most important innovations in fertility care is I think the advent of Gonotropin injections that we commonly give. So there are a lot of stigmas around the use of Gonotropin. So can you please tell me what are the advantages and disadvantages, and is the Gonotropin a boon or a pain for fertility?
Definitely it is a phone, because that too these days, like probably about 15 to 20 years back, you had lots of like not so purified products. So patients were given injection in large doses for a long number of days to get them to a place where we could extract at least about 10 oocytes. But then now we have purified forms of gonadotropin and recombinant types of gonadotropin, where actually it is more purified and it is available as on the global platform. When water is being sold in other parts of the country, other parts of the globe, is being available for us also. So that makes a lot of difference. And again, I would say that patients are always a little bit worried about taking so many days of injection. And then they actually feel that
Can you please give us a moment?
so like it used to be like we start from the 21st day, right?
In the question, but the first answer from you.
ఒరే నిమిషం ఇండియా ఒరే నిమిషం
இது வரைக்கும் பண்ணிருக்கிறதெல்லாம் கரெக்டா வந்திருக்கா?
Yeah.
Why suddenly change?
One கொஞ்சம்
Lower இருக்கா?
comparatively. What?
கீழே வச்சுட்டுமா?
சரி.
ஹலோ,
Hello.
இப்போ செக் பண்ணிக்கோங்க.
Ready?
You can start the question once again.
Yes. One of the most important innovations in fertility of recent times is the advent of the gonotropin injections. So, ma'am, can you please tell me if gonotropin is actually a boon or a bane in fertility care?
It is definitely a boon because to do an IVF program, we definitely need gonadotropins as the most important medication. It is available in injectable forms. That is one of the reasons why our patients are very skeptical or a little frightened about taking so many injections. But then, compared to what was happening about 15 to 20 years back, now the treatment protocols have changed. So where nowadays we are not doing long protocols anymore, and we do the antagonist cycle, which hardly we give hormones for about average of 8 to 10 days or 8 to 11 days max. Okay, and in cases of oocyte preservation, in case of cancer patients who are supposed to go for treatment, we can even give an ultra short treatment protocol for them to get the oocytes retrieved as early as possible so that they can continue with their treatment. So the gonadotropin injections are very important, and they form the main basis of the treatment protocols in our IUI as well as IVF. In IUI, of course, we can use medications also, oral medications also, but when it comes to IVF, injectable gonadotropins are the treatment for now. And it is definitely going, it is a very, very important thing. And here, patients require a little bit of counseling, because many people have a feeling that after taking this treatment, they will actually put on lots of weight and they develop other problems after the treatment. And that has been one of the main reasons why they hesitate going for an IVF treatment, although they know that it is a tubal block or low AMH and all those things. Thank you.
Okay, ma'am. So, moving on to the next topic, role of HSG hysteroscopy and hysteroscopy in female infertility.
I think I spoke to you about HSG already.
Yes.
So HSG is nothing but it's an X-ray which is taken to diagnose whether there's any tubal block. Next is definitely it plays a very important role in infertility. So second thing is hysteroscopy. Hysteroscopy is nothing but we just see the uterine cavity using a camera. Like how we do a laparoscopy for the abdomen, in the abdominal cavity, we use a scope and visualize the interior, inner part of your uterus or the cavity of the uterus. And this is very important in infertility because it is useful for us both for diagnosis and for treatment. For example, when we do a hysteroscopy, if we see a septum, we go and correct it. We just do a septal resection. When we see a polyp, then we can go for a polypectomy. So in that way, it is really useful. So both HSG and hysteroscopy is really going to help us in lot of ways as far as infertility is concerned.
Yeah. Okay. So now we are at alphabet I. So, ma'am, can you please tell me what is the difference in IUI, which is intrauterine insemination, and IVF or ICSI?
Okay. Intrauterine insemination is a very basic form of treatment. I would advise the couple whom I am treating for infertility, where I see that most of their tests are normal. That is, the woman's age is okay, her AMH is fine, her tubes are patent. In man, it could be normal count or low count, but they're still not conceived. So more commonly for low count, this is a very important method of treatment. So in male infertility and unexplained infertility, IUIs would be the treatment of choice. And any couple coming to us like for
infertility treatment for more than married for more than for 3 years and not conceived and not done any other treatment as so far, I would definitely take them for an IUI at least if all these other tests are normal.
Okay.
But when it comes to IVF, say 3 cycles of IUI failure would actually be motivated to do an IVF because we really don't know, because IUI has a very low success rate also. Like it's only about 15 to 20%. So after 3 cycles, if the person, I mean, if the woman is not getting pregnant, there is no point in continuing doing more IUI on her. So we would actually motivate her to go for an IVF program. So in IVF, it is a little prolonged therapy where it requires about 10 days of medication and following up with follicle scans. Both in IUI and IVF, we do the follicle scan. In IUI, like once the follicles are big and mature enough, that is more than 17 to 18 millimeters, and endometrium looks good triple line and about 8 and above, I would give her a trigger injection, ask her to come after about 36 hours, and then plan to do 36 to 48 hours also. We can take and plan and do a IUI. The husband would be giving it the sample, and then we would do an IUI. The sample will be processed in the andrology lab, and the zero 0.5 ml or zero 0.6, zero 0.5 to zero 0.6 ml of the prepared sperms will be inserted into the uterine cavity. And we give them luteal support and wait for the next 15 days, after which we do the beta HCG or a urine pregnancy test to confirm pregnancy. Whereas in IVF, it is a longer protocol where we are actually giving almost average of 10 days of injectable gonadotropins, and serial ultrasound follicular monitoring is being done and as we do the injections. When the follicles reach a size of 17 to 18 millimeter, we actually trigger, and at 36th hour we make sure that we do the oocyte pickup. And this is a little longer protocol, and after doing the pickup, the embryologist will be doing the lab work, that is the scientific work is done on them, like they do an IVF, conventional IVF or an ICSI. By day 5 they let us know how many embryos they are going to freeze. Earlier, we used to do fresh embryo transfers also, but then these days, frozen embryo transfer gives a better success rate. So we've all sort of changed over to frozen embryo transfer. So the frozen embryo transfer will be done on the subsequent cycle. Before which, probably if there is a need for hysteroscopy or hyster wash, we would be doing it and then doing the transfer. So when it comes to the cost also, IUI is a very simple procedure, costs very less to the patient. But then more than 3 cycles, if it is not happening, then IVF is the only solution. Okay, where the costs are a little higher, but then a success rate is close to 70%.
So that was elaborately explained. Thank you, ma'am. So moving to Jay, I think the most distressing part of every couple is when they go through this fertility treatment. So, Vanitha ma'am, can you please walk us through the journey of a patient during fertility treatment and how to make it easy for them?
Yeah, journey of fertility treatment, it is not same for everybody. It depends on the couples. So it might be sometimes very easy for few people and it might be a little tough for some people. So sometimes they come to me and they just become pregnant within 1 or 2 months and they say, like, you're very lucky. It's not like that. The problem was very simple. And some couples need, sometimes they are with us for 1 year, 1.5 years. They go through follicular monitoring for 6 months, then IUI, then they fail. 3 times IUI fails, 4 times fails, then we go for IVF. So sometimes the journey is really long, for about 1.5 to 2 years to get the success. Okay, so it is not the same for all the couples. But with all this, what to make it easy, first thing is they should choose the right doctor, and they have to stick on to some things. Instead of doing a lot of doctor shopping and all that, they can go for second opinion. It's not wrong, but main thing is they have to follow the doctor's instructions carefully. Basic main thing, we all as a fertility doctors, we talk to them about lifestyle modification. That's very important. So if they do all that, sometimes they conceive. We just give them 3 months time, 4 months time, they come pregnant. With weight reduction, they become pregnant. So they have to stick on to the They have to follow meticulously the instructions given by their doctors, like mainly the lifestyle modification, and followed by even medications, whatever we tell. And there's a lot of many times we see non-compliance. No, they just come to us suddenly 3 months, 6 months they'll not be there. Then they'll come back. So that is because when they don't get success, they get so depressed, upset, and all that. So in fertility treatment, I think we have to talk a lot. Like we have to sit and, as a doctor, though we have counselors, sometimes I have to sit and talk to them for 45 minutes, 1 hour, especially when the report is negative. So we have to really give them a lot of positivity, and we have to tell them a lot of examples and explain them that this is how it is. It can still, you can become pregnant. Sometimes we have good quality embryos 5, 6, and they won't become pregnant. One day 6 will be there, they'll become pregnant. So all these when we explain them all these things, they really feel positive. So in this journey, it's like a teamwork, as ma'am said about the scientific team, clinical team. We have to have good counselors, and we have to really support each other, and the journey in that way it can be easy for any even for a tough couple. We can make it easier by really talking to them and giving lot of positivity and giving them very often we have to give them counseling sessions. I think in that way it is easy for them to go through this tough journey.
Very true, ma'am. I think patient compliance is one of the most underrated things that people talk about. So the next thing is So one of the very rare investigations that we advise for patients, but it has a very big significance in certain scenarios, karyotyping. So ma'am, can you please tell me about karyotyping? When is the test performed? Who are the patients who would be benefited through this?
Yeah. Karyotyping is actually a blood test done to assess the genetic chromosomes in the person. This test in infertility where we are using is in significant cases of recurrent implantation failures, and in cases of recurrent pregnancy losses, where we want to find out what was the reason that these failures occurred. So in that, we would want to do the karyotyping of the couple. And there are other known cases of problems, like for example, a family would have a Down syndrome baby. They're a little worried, and if it is in a close family circle, they would see that child, they would be very frightened to have a child like that. So something like muscular dystrophy, a bad experience in the family actually puts them very scared of doing having a pregnancy itself. So in those cases also, we would want to do the karyotyping to find out if there is any abnormal chromosomes in them which would contribute. In many cases, we have seen in implantation failures or recurrent pregnancy losses that there is so much of the male karyotype abnormalities also, which we have seen, and we have to explain to them. Probably in those cases, we want to do the biopsy of the embryos, do an IVF to them, and then biopsy of the embryos, check the chromosomes in that embryo, and only if it is a euploid embryo, we use it. So in all these cases, commonly in recurrent implantation failure and recurrent pregnancy losses, use. Even in elderly women who are seeking pregnancies, I think we should check these things before we are like leaving them too long and then doing a test after a very long time.
Beautiful, ma'am. So next topic, we spoke about hysteroscopy in detail, ma'am. So can you please tell me about the role of laparoscopy in infertility?
As we've been telling this regularly or very frequently, laparoscopy is the diagnostic tool, or it's a gold standard in the diagnosis and treatment of infertility. So laparoscopy, it is done under anesthesia. So any couple, when they come to us after, for example, they come to us after 3 years of married life, we just tell them better we go for laparoscopy. And they've been trying for all these years. So laparoscopy is a procedure. It's a surgical procedure. It is done under general anesthesia. And as I told you, we just put 2 or 3 small incisions on the abdominal cavity, just below the umbilicus and on the lateral aspects. We just put 5 mm or maximum 10 mm incisions, and we put a laparoscope. Laparoscope is nothing but a scope with a camera. So when we insert this camera inside, we can see the abdominal cavity. Here we go and see our uterus, tubes and the ovaries. So from here we can see the outer part of the ovaries. We see the uterus from outside. In hysteroscope we see the uterus inside and the cavity part. Here we see the uterus outer part, and we can from there we can find out if there is any fibroids, any other endometriotic spots on the uterus, all that. And as far as tubes are concerned, when we do a laparoscopy, physical appearance of the tubes, whether it is normal, the fimbria is fine, is there any peritubal adhesions, is there any tubercles on the tubes. For example, if they have tuberculosis, they can have some tubercles. And again, tubal patency can also be checked when we do a laparoscopy. And when we come to the ovary, two things. One is commonly we see polycystic ovaries in infertility couples. Those days we used to do a lot of polycystic ovaries punctures. Now we don't do very regularly. We do it only if it is needed. For example, if they have their AMH is very high, or if they have very hyperandrogenic features, then we give two to three max punctures on the ovaries. That is PCO punctures. And if there's any cyst, we can do the cystectomies. And very important thing that extra we see is endometriosis, which can be missed in our ultrasound. I mean, not missed, it cannot be seen in an ultrasound. So, yeah, if you have an endometriotic cyst, we can pick up with ultrasound. But when we have a POD nodules and just endometriotic spots on the pelvis and on the our organs, laparoscopy will really make a big difference, and it will help us in diagnosing endometriosis. And in the same way, we can treat them also.
So moving to your alphabet M, which is for male infertility. I think almost one half of the infertility is contributed by the male. So can you please throw us some light on the different aspects of male infertility, ma'am?
Yeah, exactly. As you told, it is more than 50% now. Male infertility has risen. And probably the investigations done are more numbers, and that's why we get more numbers also. Because here we see young men, very healthy looking in all other aspects. But then when it comes to, like, when they have come as a couple to check for infertility, we are seeing that many of them have either, common test here is a sperm analysis. Initially, I would actually ask for sperm analysis. In the bloods, I would ask for some thyroid assessment, diabetics, because there are many young diabetics these days, less than 30 or 30 plus. We have lots of it. So all this actually causes infertility. So that is the reason we would be asking for a few blood tests, a few hormones also in the bloods, like thyroid, FSH, testosterone. But then semen analysis is the most vital test. So in the semen analysis, it could be about the sperms number count, the sperm count, the motility, and the morphology. Or sometimes if there is no sperms, it is called azoospermia. That is the sample collected, sample given for testing, did not have any sperm. These things can't be like taken as it is, because there could be an condition where it is obstructive azoospermia. So there will be sperm production, but then the sperms are not available in the sample given. So this obstructive azoospermia has to be evaluated by doing a PISA sample or a TISA sample, where we take the sperm, we take the sample semen from the epididymal region. So in that cases, we can actually assess whether sperms are available over there. In those cases, definitely IVF will be the treatment of choice. So coming to male infertility, as Dr. Vanita was just now telling, it is actually the lifestyle which is causing so many of them to have male infertility, male factor being the cause for infertility. So it could be because, like, many of our young people are working for other countries, so their diurnal rhythm has totally changed, and lack of exercise. Most of them, when the couple come to my clinic where we are actually checking their vitamin D levels, we see to our surprise that both men and women are low in their vitamin D levels. Sometimes correcting these things also can they make them have their pregnancy successfully. So male infertility is something which has to be taken right from the day when the couple come to us, rather than thinking that the woman is the cause. And The treatment protocols these days are more simplified. Probably there are so many medication which is available to improve the sperm quality, morphology, and all those things. Of course, other reasons like genetic problems has to be evaluated also. And of course, when the couple are not getting pregnant and the sperm analysis is not showing good count and all, we have to do the DNA fragmentation index also to see whether the quality of sperms is good, where we might need to advise them to go for a IVF if it is slightly low. But then if it is very bad, then we might even ask them to go for a sperm donor also. Thank you.
So I think that was very elaborately explained about male infertility. I think with the recent scientific advances, there is one new technology that is coming into the market every day. So, taking that into consideration, what are the newer techniques as far as the fertility aspects are concerned for both male and the female infertility evaluation?
Since we have started doing IVF, we ourselves have corrected so many things and we have been fine tuning day by day. What we have been practicing last before 10 years, now it is different. So definitely there are so many newer techniques, and these techniques are really helping us in giving us a very good success rate and also good healthy babies they can take home. So that's the advantage of all these newer techniques, which we use regularly. Is for men we have a lot of things. That is two things we have. One is when they have azoospermia report, or when they have low counts and motility, or sometimes when they come to us with very one or two motile sperms, is the report of that semen analysis. For these couples, we use a lot of extraction techniques nowadays. That is PISA, TISA, or microscopic TSA. These three things will help us in selecting and taking one or two good sperms from the male partner. Second thing is in sperm selection. We have microfluidics nowadays, and we have IMSI. These two, later technologies have really helped us in selecting the good sperm. So these two advances have really helped us in treating the male factor in a very good way. So the results are much better when we are using all these newer technologies for male partners. The other things for women, when we look into it, nowadays we have PGTA. We have been discussing all these things. So pre-implantation genetic testing for aneuploidy. So when we have, as ma'am was telling about recurrent implantation failure and all that, we definitely, or recurrent pregnancy losses also, we can go in for PGT. And especially this is done for women more than 38, 40 years of age when they come to us. All these patients are really benefited with PGTA, where we select, after we form an embryo, day 5 of an embryo, we just take few cells and we read that for the chromosomal study. And we pick up the really good normal chromosomal baby, and then we put it into the uterus. That is, we do the transfer of only the euploid embryos, and the abnormal embryos are left out. So this is really very, it is really giving us a lot of success rates, especially in the recurrent IVF. When they come to us with 2 IVF failures, 3 IVF failures, we really succeed by doing this PGTA. The second thing is endometrial receptivity array. Even this has really helped us when we do this. With again, this is mainly for, not for all the patients we're going to go do this. When they come to us with recurrent IVF, previous 2-3 failures only, we do all these newer techniques. So in ERA, we just take an endometrial sample. We prepare the patient like how we prepare them for the embryo transfer. We prepare the endometrium and we go and take a sample, and we read that endometrium and we find out the optimal time for embryo implantation. We see that exact window of implantation and we do the transfer accordingly. In that way, we really get success rates, and these two are really changed in the numbers, like in the success rates really we have gone up. Along with that, we have nowadays cryopreservation techniques, which is really useful, especially in women. We see nowadays a lot of youngsters with malignancies like breast cancers. 28, we look patients with a lot of cancers nowadays. So in these couples, or if the girl wanted to postpone a pregnancy and she wants to go abroad and come back, and she wants to plan her pregnancy later for social reasons, even for them, this cryopreservation is very useful. That is, we give them stimulation of We stimulate the ovaries, we collect the eggs, and we freeze it. We freeze it, and it can be used later when they want to do it. We can use it. So, yeah, this is called fertility preservation technique, and this is very useful mainly for our cancer patients. These, I mean, we have many more, but we regularly use all these things nowadays, and it has really improved our success rates.
So
Thank you.
that's beautiful, ma'am. So just to add one more point to the PGTA, even for genetically inheritable diseases, nowadays we
Yes.
can use PGTA
Yeah.
to select the embryos
Yeah.
wherein the specific disease cannot be inherited.
Monosomal and single gene defects also we have.
Things also. So moving to O.
Mhm.
So I think of late there is an increased demand for oocyte donors and sperm donors, ma'am. So can you please explain on the rising incidences of the requirement of donor and which are the patients who would benefit by going for an oocyte donor?
Okay. As we already discussed, it is the low AMH or very low AMH which requires a oocyte donor because she is not capable of producing her own eggs. It might be because of various reasons. It could be as simple as age. They are only trying when the woman is around 40 and her AMH is 0.2 or less than that. So at that time, but they're bent upon having a pregnancy. So in those cases, we have to talk to them about the oocyte donor. There are other cases where the other end of the spectrum is a very young girl who's only 30 years, but then her AMH also is low. We call it as poor ovarian reserve. Yeah, yeah, aging, premature ovarian or premature ovarian. Ovarian reserve, low ovarian reserve. So in these conditions, definitely, if the count AMH is very very low, then we definitely have to take them as a case which requires oocyte donor and ICSI. If the male partner has good sperms, then we will use his sperms and use the donor oocytes, and the embryos which are produced after the ICSI, we would be actually transferring it to the woman who's intending to get pregnant. So donor oocyte programs are on a rise these days because of many people planning for pregnancy a little too late. One, and because of the diseases like endometriosis and such conditions where the ovarian damage is bad, like even in ovarian endometriosis, we see that the cysts are so big sometimes when the patient comes to us. Although we do laparoscopy and all those things, we don't see any healthy normal tissue at all. So sometimes if there is a low AMH in those people, we do tend to stimulate and see. But stimulation after 5 days, if we are getting good follicles, we will continue. But otherwise, we will stop and advise them to come for a donor oocyte program. So donor oocyte programs and surrogacy, all these have come under the Art Bill now. Since 2022 January, I think a new law is amended. So we have to select a donor. Of course, the donor selection is based on the couple's what they want, like the skin color, the hair color, all those things. And usually, it used to be that the donors are not known to the couple, but then now the law actually says that they can get their own donor also. So the law has changed now. So if a couple says that they want to get the donor eggs from this particular person, we can still do it. So that this thing liberty or that law is available now for the people. Or otherwise, it is. I mean, most people don't want to us to let them know who the donor is. So in those cases, we will be finding a donor. And now the laws are very stringent that we are not supposed to, and the donor is not supposed to donate more than once. Earlier, they could donate up till about 6 times, but then now they are not supposed to donate more than once. So those things also have to be kept in mind when we are checking with the donor cycles. And here we select the donor who has a good AMH. She has to be in a good BMI, that is body mass index also should be good. and preferably because the law says again you can take only about 7 oocytes from them. So that all these things, no, so we have to be very careful in choosing our donor also. So the stimulation will almost be the same whether it is a self cycle or to a donor. We're going to use the same gonadotropins and do the stimulation. The egg pickup also will be done in the same manner. But then after the oocytes are donated, the donor will, I mean, they will be going off like probably with some treatment which is needed for the next 5 days or 6 days. So, but donor cycle programs are giving good results in cases where the AMH was very low, because earlier cycles the same couple would have tried own self eggs, but they would not have got pregnant. But when the cause is something like this, as a low AMH or bad ovaries or something like that, but only if the uterus is normal, we can provide them donor oocytes and transfer the embryo in them, and the results are as good as 75 to 80% also in these cases.
Thank you. It's very informative. So, Manita ma'am, I'm going to ask you a very common question. So, of late, we see a lot of patients with polycystic ovarian syndrome. So, my question is, can a PCO woman be able to conceive without any help?
Yes.
Or what is the fertility aspect of a PCO woman?
Okay. Definitely, they can conceive without any treatment. Because we see nowadays a lot of youngsters, like even schoolgirls, coming with PCOS. So I think it's the treatment or whatever, we should start counseling the mothers and the kids if they come to us very early, as early as 13, 14 years. So that should start from there. Coming to your question, yes, PCOS can be treated and we can give them babies without much treatment. So lifestyle modification is the basic thing in polycystic ovaries. As we all know, PCOS, they come to us with history of irregular periods, or they come with weight gain, acne, and all that. So first thing is we have to tell them that to reduce their weight, and definitely they have to do some physical activity at least for 1 hour per day if they have time, even 2 hours per day if time permits. So physical activity and diet control, they have to concentrate on their diet. They have to reduce their carbs. They have to change to a lot of millets instead of taking a lot of rice. They have to change their food habits. They have to take a lot of fresh fruits, vegetables. They have to drink adequate water and good sleep patterns. And very important thing is their stress levels. Whether they are a student or office, the stress can be at home or at office, anywhere. So we have to talk to them about all these things, and we can tell them to go for some yoga or meditation. All these things will definitely make them really fertile. And once we tell them, like, as less as 5% reduction in body weight can resume their periods back. It is not very tough. Like, even if a person is coming to us with 90 kgs, just we tell them we don't have to reduce 20 kgs or 30 kgs for her to become pregnant. Just 5% of body weight is nothing but 4.5 to 5 kgs. So when we tell that, they get that boost, like, okay, it's easy, it's not that tough. So the way we counsel, and definitely we can conceive, make them pregnant without any treatment. This is the first thing. When if they are, see, we have to give them some time, take 3 months or 6 months, reduce your weight, do all the lifestyle, then come back. When they come to us, if still they are not able to conceive, then we have to go into medications like ovulation induction, and just goes from there. So very take home messages, definitely they can conceive without any treatment if they really follow.
Let us know, because many people won't have any good tools. Anovulatory cycles are very, very common. So we could actually guide them by doing a follicular scan and advising them which are the fertile days like.
Okay, so next question to ma'am. Ma'am, we spoke about the role of embryologist in the team, and we spoke about the lab and all those things. Now, my question is regarding the QA/QC of lab, the quality assurance and quality control. How important are the lab parameters in determining the success during fertility treatment?
It's very important, because this is something which actually gives us the results to our patients. When they are coming to us for the treatment, they would expect, say within 3 months or 6 months down the line, they would want to go home with a urine test positive or a baby in hand. So when you want to do this, your lab has to be maintaining that much of standards. So quality assurance is something like we are maintaining that much of standards to create good quality embryos in our lab. And the quality control would be like if there is any problems which we are facing in the lab, be it as mm, less number of embryos forming, or we should definitely look into what is the problems related to it. Is it the incubators, or it is the temperature, or during that particular cycle was there any media problem, any of those things. So those things has to be checked, and that has to be brought back into proper control. So by doing this, our whatever we are talking to the patient, like an IVF or an IVF, whether it is conventional or IVF ICSI, we are telling them we can give you 70% of success rate. So this is possible when the QA QC of the lab is maintained very strictly. So for this, actually, the lab people, that is our embryologists, the andrology team, and the people who are inside who maintain the lab is very, very important on a day to day basis. And for that reason, we actually have our in house embryologists, because many centers will just have embryologists walking in and going out. So they would not be knowing what is actually going wrong in the lab many a times. But the in house embryologist makes the difference, because they're every day monitoring the lab, even for the particulate matter, even for the VOC, all those things they will be checking on a day to day basis also.
Thank you, ma'am. So, next question. I think this is going to be the nightmare for the clinicians, the patients, and everyone. Recurrent implantation failure and recurrent pregnancy loss.
Yeah.
Can you explain what is it and how do we manage such a scenario, ma'am?
Recurrent implantation failure is defined as when we transfer a good quality embryo, still we are not able to get the embryo implanted. So that happens recurrently, like 2 or 3 times when we do embryo transfer and there is a failure. That is called as recurrent implantation failure. This is only for the IVF patients. So here again we have to go and check what is the cause. The treatment is according to the cause. So it can be a defect with the embryo, or it can be a defect on the endometrium. There's only 2 things that it's playing there. So as far as embryo is concerned, we have to see whether how was the quality of the embryo. How was if there is a poor quality embryo, we can have recurrent implantation failure. Or sometimes if they have any chromosomal abnormalities, all these things can be prevented by doing a PGTA we discussed earlier. So if there is a poor quality embryo, or if they have a chromosomal problem in that embryo, then we can have a recurrent implantation failure. This is as far as embryo is concerned. As far as endometrium is concerned, again we have to look into it. It can be any structural thing, as like polyp or some. Usually we do a pre-IVF sometimes, a pre-IVF hysteroscopy, or sometimes it can be missed, or it can be a new polyp which has come. So we can do an hysteroscopy and find out if there is anything inside, polyp or any a small septum, whatever it is, that can be done, and it can be improved by, if everything is fine. For example, hysteroscopy is normal, then we can go in for endometrial receptivity array, which I told you earlier. So in this, again, we will find out the exact window of implantation, and in that exact time, we will go and transfer the embryo. In that way, we can prevent the next loss, the next failure. So this is recurrent implantation failure. Recurrent pregnancy loss is after they become pregnant. We have done an IVF or even a normal pregnancy, whatever. When we have 2 or 3 consecutive miscarriages or pregnancy losses, we call it as a recurrent pregnancy losses. So here again, we have to go back and evaluate them. In recurrent pregnancy loss, basically we do a hemoglobin, thyroid, sugars are also they are very basic things, but sometimes high sugars can be the reason. Common is hypothyroidism. Many people, they won't even know that they have a thyroid problem. So we have to do the TSH and blood sugar levels. And again, other causes are uterine anomalies. There can be a polyp or a septum. Even that can cause a recurrent pregnancy loss. And so definitely male factor. We have to look into the semen parameters also. So when we do all these, and when we have recurrent pregnancy loss, we do APLA or autoimmune diseases has to be checked. Last but not the least, karyotyping for both the partners. And by treatment is according to the cause. So we have to do all these things and then treat the patient according to the cause, and that will really help us in the next pregnancy.
Thank you, ma'am. So moving to the alphabet S, I think ma'am spoke about the ART bill and the amendments. So S for surrogacy, ma'am. Tell us what are the indications for a couple to opt for surrogacy and what are the challenges that we as clinicians face?
Yeah, surrogacy is actually a third party treatment, fertility treatment, where actually we have a woman who is going to carry the pregnancy for the couple, intending couple. So in this thing, it could be because that the woman does not have good health to carry on with a healthy pregnancy. It could be basically like she has a severe cardiac disease, she has a renal problem, or she has a uterus which is not good enough or big enough to carry a pregnancy. So all these factors, it is that she can't carry her own pregnancy, only then we can go for surrogacy, because surrogacy is a third party. I mean, the person who's carrying the pregnancy is a person, should be now according to the new law, it should be an altruistic surrogacy, where the person who's going to carry the pregnancy for them should be known to them and should be coming to help them for the pregnancy. Okay, so that is the reason. In this case, the surrogate mother, we have to assess the surrogate mother also about her health, about her uterus, before we plan for using her as a surrogate mother. And in this case, we should make sure that the surrogate mother should also be a mother, so she should have had a healthy pregnancy. So that should be the thing. So this is like, there were some stringent laws coming up very recently. That's why, like, for a brief time we had all stopped doing surrogacy cases, but then now the law is more clearer, so we actually do now. So we have to get the legal and the permissions from the Directorate of Medical Services to go ahead and make sure for what reason we are actually using a surrogate mother for that couple. So in that, by doing that, we are able to help the couple whose the woman's health is not good to carry a pregnancy. Okay.
I think. Okay. Shall we end up? I think because of time constraint, I think we will have to wind up the session and take up some questions. We have time.
If we get over by
I thought
4:30, we'll stop now. Yeah.
Do we have time or do we continue?
We have 10 minutes more and have questions.
Okay, then we'll finish off first. We have for 5 or 6 more questions. Okay. 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 Is it live or we pause?
Right. Go ahead.
Okay, fine. So we'll move on to the alphabet T, ma'am. So the transfer of embryo is the most important aspect. So how do we prepare a patient for the transfer of embryos?
Yeah. Embryo transfer is of two types. One is fresh embryo transfer, the other one is the frozen embryo transfer, as we told already. We have been doing always fresh embryo transfers. Now we have switched on to the frozen embryo transfers as our results are much better. According to the lab, it varies, but definitely better than the fresh embryo transfer. So when we plan for a embryo transfer for a patient, we call the patient on the day 1 or day 2 of her periods, and we start preparing her endometrium. We give her estrogen and some other supporters, and we prepare her endometrium, and we again scan her on day 10 of her periods, and we do a serum progesterone level. And from day 11 to day 15 or day 16, we start progesterone along with estrogen, and again we scan her on day 15. And again, we do the serum progesterone level. If the endometrium is good, that is, it should be a triple line. There should not be any echogenicity, and there should not be any fluid. And the endometrium should be at least minimum more than 7 to 8 mm. Then the endometrium is good. We call it as a good endometrium or a receptive endometrium, and the vascularity also should be good. Then we take them for embryo transfer, and the progesterone levels also should be somewhere between 10 to 15. Then it's an ideal time for them for going in for transfer. So if we have a day 5 embryo, we transfer the day 5 embryo on the 16th day of her cycle. So we prepare the endometrium and do the embryo transfer.
Thank you.
Even day 6 transfer.
Day 6 transfers also we are doing nowadays. And we are getting good results also.
Okay, so moving on to unexplained infertility, ma'am. We already spoke about it, but can you just elaborate a little more on?
Unexplained infertility is a group of couple who are actually coming with seeking fertility treatment, but then when we examine them, be it a clinical examination or hormonal assessment, scans, semen analysis, both the partners are very healthy according to all the reports we have seen. And in spite of us giving them the basic medication to do the ovulations induction and timed intercourse repeatedly, sometimes they fail. And such couple, we usually take them to IUI. Most of them conceive by IUI also. Okay, but if there is unexplained infertility, uh, the causes might be something like a thick oocyte this thing capsule, the zona, thick zona, or it could be a poor sperm acrosomal cap. So this is something like the researchers are talking about. So that is the reason, although they have everything else normal, there is something not happening. Okay, so in these cases, even if the IUI is failing, then in that cases, some of them, like about 15 to 20% of the unexplained infertility patients will definitely require IVF also as the treatment modality.
Thank you, ma'am. So moving on to vitrification. So we are at V now, vitrification or cryopreservation of gametes and embryos. So can you please elaborate on?
This is nothing but cryopreservation, which I discussed a bit earlier. This is nothing but we are just freezing the gametes or the embryos. Vitrification is done at minus 196 degrees Celsius with using liquid nitrogen. So in vitrification really has changed the fertility thing itself, because as we discussed, in especially in the cancer patients, vitrification has really played a major role in preserving the oocytes, and also for the social freezing also. It has really increased our chances of fertility, both for the males and female couples. Anything else?
In male, cryopreservation of the sperms is usually done in IVF cases. We do a backup sample freezing always, because on the day of egg pickup, sometimes the husband is not available because of his work, or sometimes the couple might be staying in different countries and the woman would be here. So in those cases also, we do sperm cryopreservation in large numbers. Embryo cryopreservation is of course done in all IVF cases. Yeah.
Even for recently, we had few cases where husbands are staying abroad, and so we are going on doing IUIs with the sample which has been frozen already. It's really useful, because today's culture is like that. See, we can't tell the husband to stay here. They have their own goals and financial commitments. So it is really useful in treating such couples.
She had a patient also who was abroad. When he came to India, he had given the sample and gone. And we used it when the woman was ready to.
He came back. So the husband doesn't have to stay at the time of the treatment.
Yeah.
Just add one more point, I think even in pediatric malignancies, prepubertal girls and boys also, we can use this technique to actually freeze their gametes so that it can be used at a later phase of life when they completely recover out of their malignancy. Tissue preservation. Oocyte, yes. Ovarian tissue and testicular tissue cryopreservation. Okay, so moving on to what are the do's and don'ts during a fertility treatment for a couple that we advise?
Actually, the do's is start early. There should not be any hesitation, and they should come together. the couple should always be together when in their infertility treatment journey, which will actually give us very quick results, very quick. I mean, quickly. And we are like, both of them are, when they are coming and attending the clinic, we meet them as consultant clinicians. Our counselors meet them. Sometimes we even ask our embryologist to meet them also. So, like as in cases where there is very few sperms in the sample, or we want to do planning for a TISA, PISA, and all, they would want to know more about what we are going to do. So here we allow our embryologist also to talk to them, and in the same way, like we are actually asking them to start treatment as early as possible, especially when there is something like a tubal block. There is no point in people going here there for treatment. Sometimes they go in for ayurvedic treatment, natural methods and all, which might not actually help. So these are certain conditions where we know that only treatment with IVF would help them, especially when there is a low count. We tell them about it. If they take it and start the treatment early, even by natural cycle, they might conceive. But then if they, I mean, as we were talking, like we know that career oriented profiles are more these days. People who are career oriented are more these days, both men and women. So they don't want to leave their job, but they then yet want to have the treatment. The time constraints are there on them, because all these treatments require some time for themselves, and then only we can do. So the do's are really, just be like as early as possible, have your pregnancies. Do not delay, because when we delay, then we are going to all other treatment modalities. Your IUI, IVF, donor, surrogacy, everything will come after that only. So the don'ts would be like, again, when an advice is given or probably a treatment has been started, I think sticking on to that treatment is very important, rather than stopping at one time and again coming back after 1 year. Then, or you go 2 3 places, again come back. So which could have been done in the next 1 or 2 months, then we'll do it only after a year. So that sort of a thing. Otherwise, the other do's are like healthy diet, lifestyle changes, exercise on a daily basis is going to be very important. PCODs, especially those are on the obesity side, they have to take their treatment very seriously.
Okay, ma'am. So moving on to a very rare condition which is called as exomonosomy or Turner syndrome. So do these patients have a chance to become pregnant, madam?
Yeah, Turner syndrome, they can become pregnant, but it depends. We have to see in this patients, we have something called streak ovaries. We just have a small piece of ovary. Usually, it will not be that very active. We will not be able to stimulate and get eggs from those ovaries. So, usually, we talk to them about donor oocytes. So, they can become pregnant with the donor oocyte and the husband's sperm, provided their uterus is little okay. If the uterus is of adequate size, we can go for OD-ICSI and we can make her pregnant. If still we feel the uterus is not okay, if the size is not good, very hypoplastic, then we can suggest them to go for surrogacy. It's not that they cannot become pregnant, they need all this help and they have to understand the process and they have to go through it. Anyway, it's very rare, so we don't see much of
when we come across
such patients. We have to really help them out by counseling, and it's again couple counseling is more important when they come to us.
Thank you, ma'am. Again, a very rare entity of male infertility, which is Y chromosome microdeletion.
Yeah.
We don't see those patients very often, but can you please explain about what it is?
Yeah, actually, Y microsome microdeletion is a condition in which is commonly seen, not very commonly seen, but then is one type of fertility issue in a man, where actually there are missing genes on the Y chromosome. So this can be assessed, like when there is a patient who has low count or very less count. This is where we check whether the Y chromosome deletion, microdeletion is there. It's a blood test which is being done, through which we can identify the problem. So because there is low count available, we can always advise them to go for IVF treatment, if it is possible to use those sperms, we can go for IVF treatment, but we can also do the biopsy of the embryos before transferring. It is possible, but they need treatment and they need a detection also.
Okay. So the final topic of the day, I think, is Z for zona hatching. So can you please explain what is laser-assisted hatching and which are the patients who would be benefited by going for a laser-assisted hatching?
As we all know, zona pellucida is the covering of the egg or the eggshell, we can tell it as. So for some people, it will be very thick, and especially in patients, very old patients, more than 38 or 40 years, or patients with PCOS and all, they have a very thick shell. Yeah, the shell will be very thick. So laser assisted zona hatching can be used in these couples, where we just use a laser and make a small breach in the shell of that embryo so that it can hatch easily. So when they do ICSI, they can find out if it is very thick. The embryologist will be able to make out. So they will use this on day 5 embryos to hatch it easily. So this is really again a game changer in our fertility treatments. So many of them will conceive with when they have failures, they really make a difference and they can conceive with this technique. So implantation is better after doing zona hatching.
It is also used in PGT.
Yeah,
Pre-implantation
pre-implantation
they use
testing
the
also.
hatching so that the tropodyl cells pop out and then
They
take
can
the
collect it
biopsy.
for biopsy.
I think with this, we have come to the end of this session today. So I think there are a few questions that have been posed by our audience. So I'll just read them one by one, madam. So the first question is there a risk or side effect associated with fertility medications or treatment? So that I think we've already discussed.
Yeah, when you're using it in the right way, controlled ovarian hyperstimulation, definitely we won't have much of side effects. All these doses are decided according to the AMH and AFC of the patient. So when we do it in the right way, there are not much of side effects nowadays.
So,
There was actually some time back, there were cases of ovarian hyperstimulation, which was on a high numbers. So that has actually made many of our patients seeking IVF because they read all these things on the Google and all those things. But then, definitely, to my knowledge, over the last 10 years, I have not seen even one case of ovarian hyperstimulation which needed an admission into the hospital. It is managed the way we need to manage because we do antagonist cycle, and when we use a trigger, we are not using HCG, but we used the other medication. So agonist trigger for these patients so that they won't have those problems at all. And as Vanita was telling, it is both AMH and AFC is very important in deciding the dose for each patient. It is actually tailor made.
exactly, I think it's perfect. So no irrational use of gonadotropins, and it has to be done in a center where we can be able to monitor the patients and do a follow-up. So next question is, what is normal fertility and when does one become infertile?
When a husband and wife stays together and had regular intercourse, unprotected intercourse, and still if they are not able to conceive after one whole year, then they are called as infertile couples. So what is the next, the second part of the question?
What is normal fertility?
Yeah, if they conceive within that, it's fine. Even after one whole year, if they're not able to conceive, then
Then
they
we
have to
call
come
it as
and
infertility.
seek help.
Okay, if the first IVF is successful, can the parents go for second child in the using the same IVF too?
Yes,
Yes.
100%.
We can
They
Depending
use
have
on the
the
number of
embryos.
embryos, we have cryopreserved.
So
we
we can
have-
use the cryopreserved embryos even after up to
Many
10 years.
times we have delivered second
second
babies
child.
with the same embryos.
I think even up to 10 years we can freeze the embryos and we can use them. Okay, so how to increase the chances of fertility? I think we have already elaborately discussed about it. So moving to the next question. How long should we try to conceive before seeking help? So
At least one whole year,
one of
staying
unprotected,
together.
of unprotected intercourse. Okay, so the next question is a little interesting. How can we cope with the emotional stress of infertility?
Yeah, it is a very important question. So that is the reason I was telling you, when it comes to an IVF unit, we are there as clinicians to talk to our couple, the couple seeking treatment. But then more than that, we have our counselors also. So they will be able to sort of spend time with the couple, because as clinicians we might be assessing them, investigating them, coming to a diagnosis. Look, treatment of infertility need not be for years. Okay, it can be within a week's time we can actually tell them the diagnosis and what treatment they would require max. Or in there is something like we need to do an HSG or a laparoscopy, those things require a little timing, like we need to ask them to come between the 7th day to 10th day and all those things. So those things require a little bit extra time on that couple. But otherwise, infertility treatment and infertility problems, I think, is very big for people who are just not addressing it properly. Okay, because they are like one day or one time they're attending one clinic, they use those medication for 1 month 2 month, but then they stop, then again they're attending another clinic or whatever. There are people, I get patients from a little periphery, where the husband would not have undergone a semen analysis for years. So that is sort of unacceptable. So actually infertility treatment actually becomes emotionally as a burden for that couple, because they are trying too long. But then if there is a solution, if you have a diagnosis, you should have a solution. And the solution would be something like, whether it is a natural conceiving with some help, or it could be something like do an IUI, or max do an IVF. Look, if there are people who have something, as I told you, the health of the woman does not admit her to bear the pregnancy, bear the baby. So in that case, then we would advise them to go for surrogacy also. Okay, low AMH, no AMH or undetectable, we have oocyte donation as the solution. So in all places there is solutions, but it is the way they have to accept what is available and go forwards. I know it is emotionally very difficult for anyone not to have a child in a given time, or because this becomes a social stigma also in many families. That is also there.
I think we have to really be kind, and we have to give our time and make them all right. We have to give them that emotional support, and we have to really tell them to be very positive. Even after 3 failures, they can conceive. So they should not lose hope, and they should not see what happens is sometimes when they're very upset, they stop all the treatment for 2 years, 3 years. With AMH1, they'll come with 0.1. So that is the mistake that they should not. So they should not do. Even if they're emotionally upset, I think we have to give them counseling and all possible ways of positive things and make them all right.
Exactly. So as ma'am said,
one thing I have seen is the couple who come with a very positive thought.
They really conceive soon.
Even the first
Exactly.
cycle.
Exactly, ma'am. That
Be
happens.
it an IUI or IVF also. The people
First
who come
cycle,
smilingly
whether-
inside to the clinic and talk to us very happily and discuss with us what I can do, what next, and all those things. No, they are the ones who actually, the woman conceives very quickly. 1 or 2 cycles that will be with them, but then they'll be like.
Because they come to us with a lot of trust, I feel. When they trust you, they just follow strictly what you say, and then with that, it really helps.
Stress is a very major factor that is so often overlooked, actually. So as ma'am said, we all have a beautiful team with us, a team of counselors and embryologists and a clinicians team. I think the right time to seek help will go a long way in reducing the emotional stress and burden from the patient's point of view as well.
Also, the family should support them. That's what I really feel, because I tell all my patients, see, you come to me once in a month or once or twice in a month, but really the husband or the parents or the in-laws, I think I really try to talk to them also. I tell them, bring your parents or in-laws, so that they also understand, so that they really, all these things makes big difference. So we should counsel the family too, along with the patients and couples.
So I think with this we'll call it a day. So thank you, Dakshani ma'am. Thank you, Anita ma'am.
Thank you, Rajni, for really
thank you, ma'am.
Interesting discussion.
I think it would have been very useful and informative session as well. So with this we'll wind up. So thank you.
Thank you.
If you have any further doubts or anything, you can put it across in the comment section. So we will be ready to help you at any point of time. Thank you.